All right, all right, very good. So just by way of introduction, everybody who's a clinician has, in whatever state, generally has a board that is there to help make sure, really, it's about protecting the actual participants. So in this case, the physicians and the podiatrists, they're part of the same board for the State Medical Board of Ohio, but also protecting the citizens. And the concept here is basically we police ourselves, and if we do it well enough, nobody else will try to step in and police us on our behalf, which usually is worse. So that's really how this evolved. And you know that there's a lot of movement now towards even national type licensure, things of that nature, even though there will still be scrutiny over individual practices. So this is a new requirement, although I say new in quotes because it isn't really new. We've always been expected to police ourselves. And in this case, it's a little bit more distasteful, I think, to a lot of people. Even the webinar goes into that a little bit with Dr. Levine, who's been around a lot of years. Some of you may know Steve Levine over the years. He's on the video talking about this because of the sexual connotations that come up in this reporting. The concept here is to report each other if we suspect that somebody's doing something improper, including sex with a patient, which is why Dr. Levine was part of this video. So this became effective already. So when doctors go to renew, and again, podiatrists are part of this, when doctors go to renew their licenses, they will be required to show that they've done this. I think the way I did it, it looked like it was electronic, so I think they already know. But so they will not let you renew if you've not completed this anytime after May 31st of this year. So the concept here is a duty to report, some information about sexual misconduct, and then how to report. I'll walk through all three of those and obviously ask questions along the way if you want and so forth. It's all about misconduct, and you can see here that sexual misconduct could be impairment. You think the physician is impaired in some fashion. Maybe they're practicing below the minimal standard of care, which gets into my other area of interest, my forensic psychiatry interest. And I do sometimes do malpractice cases as an expert and so forth. So that gets into the standard of care. And then improper prescribing of controlled substances. And you can see here that if you don't report, so imagine that I know Dr. Jones, maybe we work in the same group practice, we're in the same system, and I become aware that I'm concerned about his or her practice. If I don't report it and then something bad happens and somebody figures out that I probably would have had awareness of this and didn't report it, then I can get in trouble as well, up to $20,000. There's even one case, my understanding, where it was so egregious that the other person who didn't report also had their license suspended for a period of time. So they do take this seriously. And again, that's because they need to show the citizens that we are policing ourselves appropriately and not just looking the way because, hey, it's doctors policing doctors, or if it's the social work board, social workers policing social workers, and so forth. So this is specifically a medical board requirement. And I think the other thing I should mention here is that I often make the joke, although clearly it's a tongue-in-cheek, the CME requirements for physicians are not very proscribed. We don't have a list of certain types of CMEs we must obtain in a given time. We do have to get 50 hours of the category 1 and the AOA category 1 for the DOs, but we don't have to do like an ethics one. Almost every other specialty, perhaps every other specialty, has to do non-physicians, that is, has to do an ethics one. So I often joke that that's because doctors are inherently ethical. We don't have to get an actual training in that. Well, obviously that's not always true. And so this is to get at some of that. This gets into the ethics of our practices and reporting each other if we think there's an issue. So I already mentioned this about the role of the medical board. Sorry about the phone. Really, they're setting the standard of care. They will do evaluations. They will set judgments on whether issues brought to their attention are above the standard of care or not. And and then set expectations for that. Ultimately, courts of law will determine whether the standard of care was met or not. That's where malpractice suits come in. But the boards are trying to set the standard of care, give you your scope of practice within that, and then obviously set expectations, one of which is reporting certain items under the law, as well as reporting each other if we have concerns about another person. It also does protect us from wrongful accusations. So there are a number of cases. I know a few of the psychiatrists who do the reviews of physicians when these cases come up to the board. They do it very quietly in the background. It's done with a lot of discretion, but it often protects those people from the wrongful accusation. So they'll do an evaluation, and they will determine often there was no cause, and then it goes away. Obviously stressful for the physician at the time, but it goes away, and it actually protects him or her as opposed to causing problems. So then the second piece, as I said before, is protecting the doctor-patient relationship. And that, of course, is key here as far as improprieties and things of that nature. I'll say this again at the end, but you can file this complaint with the medical board. They've got a way to do this 24/7. There's a complaint hotline. SMBO is the State Medical Board of Ohio, and there's your number there, or online at med.ohio.gov. So they make it pretty straightforward. And they do keep it completely confidential. Now, obviously, if it's against a person in some fashion, they may have to get others involved, but it's not something that they magically put in the Akron Beacon Journal or the Cleveland Plain Dealer or something. They really do keep these confidential up to the point of when they need to do public reporting about what's going on. So if you look at the medical board website, you can see if a physician, once they've made a determination, has his or her license affected in some fashion with a consent decree or a suspension or what have you. That does end up being on there, and often with a lot of detail. So it's confidential complaints, but when they make a final resolution, if it's not in favor of the physician, it will often show up on that website. So just be aware of that as well. When I was at North Coast, we happily, because it worked out very well in almost every circumstance, would receive individuals from many boards, the pharmacy board, the medical board, who had had something going on in the background that affected their license. They were doing well enough. They were put under a consent decree where we would then have to do a quarterly report on how he or she was doing in their practice. And there's a lot of layers at the state hospital, so there's a lot of way to see how they were doing. And we really had no issues as far as their actual practice for anybody. Actually, in the 14 years I was there, we had one person who ended up doing criminal behavior that was a pharmacist that had nothing to do actually with what we were supposed to watch, and that did not go well for him afterwards, but didn't really affect what we were doing for the pharmacy board. So the law, you know this already, but certain things you have to report are things like knowledge of a crime, a gunshot wound, a stab wound, a suspicious burn or injury, which of course often more gets into the child abuse and neglect arena, but this could be anybody. We do like to protect adults and elders as well, so get into elder abuse circumstances there. They single out individuals with intellectual disability and or developmental disabilities, because of course they are also vulnerable, and then sexual battery, which falls under this reporting piece as well. In particular, that's one that they, based on the video, that they're very focused on. So those are laws. And then the rule, which comes from the state medical board, a little bit less power than a law, but still pretty strong because they can pull your license. So it's still very important, is misconduct. And then, of course, making sure you meet the criteria to renew your licensing, which includes the CME requirements for the people. So your duty report is to the board. And I want to just emphasize most importantly here. So if you're working in an organization and you report something, let's say I report Dr. Jones to her supervisor, that doesn't count. So you may, under the rules of the organization, have to do that, but you also have to go to the board, and you can't just assume that the supervisor went to the board. And that was actually a little bit of a surprise to me. I would think that there should be allowance if I'm certain that my supervisor and Dr. Jones' supervisor has already reached out to the medical board, that I shouldn't have to do it. It sounds like they want us to also do it. So just be aware there's a stronger onus on us to actually be the one to report. And the net result is they're going to come back and talk to us anyway if we've made the report, again, confidentially. So you might as well go ahead and put yourself out there and say, hey, yes, I'm the one making the complaint, even if your and or your colleague supervisor also makes that, or law enforcement, right? So sometimes there's criminal potential here. That's not really our area, but what we suspect is wrongdoing on the part of a colleague might involve legal issues, not just, in quotes, ethical issues, at which point that also may, of course, come to play here. So a big portion of this training was to get at why we physicians often don't report our colleagues. And of course, the list is lengthy, but a lot of it gets into relationships, right? You don't want to, if I'm working alongside Dr. Jones and I think she's doing something improper with a patient in particular, I don't want to ruin that relationship. It's going to be awkward. Maybe I'm wrong. I don't want to get her in trouble, that kind of thing. I may become who I become aware of it's also guilty, right? So maybe I'm also doing something with a patient and I don't want to report her because maybe it'll blow back on me and I'll get in trouble. So then you've got, if you will, nonverbal collusion between individuals who are both doing misconduct. You don't want to stress them out, right? We're all stressed. Under COVID, we're more stressed. Burnout, compassion fatigue, the various words that are out there, which I know they try to define individually. I suspect they mostly overlap. We don't want to do that to a colleague. So it's probably not real. I probably misunderstood what I saw or heard. You say, hey, the patient's an adult. And if he wants to sleep with his doctor and they're both consenting adults, I don't need to worry about that. So that's the concept here is we'll rationalize it, mostly because of those first three, right? We don't want to, or two of those three, we don't want to ruin our relationship. And maybe some people just don't like the rule. Hey, we shouldn't have to police ourselves. I don't have to report other people. That's not my job. I'm not here to do that. And in reality, of course, that's not up to us. That's up to the state medical board of whatever state you're in this case, Ohio. And so that is the issue. The vast majority of cases, my understanding is actually there's more false accusations that come up that don't come to fruition. It may lead to more of a added awareness for the clinician. Hey, hey, all right, now I know I got to be extra careful. We in this forum here probably have a lot more understanding about personality disorder and how that can play out negatively in a doctor-patient relationship, but not all specialties are trained in that very well. So you can imagine, for example, an OBGYN, how he or she, be given the intimate nature of the exams, there might be misinterpretation that could get thrown to the medical board to look at, and that would be awkward, although perhaps particularly in those cases, perfectly acceptable conduct, because you've got to be intimate to do the exam, that kind of thing. Whereas in psychiatry, if we're doing anything with the patient's clothes off, it's certainly not what we're supposed to be doing. So there's a difference here depending on your specialty. Excuse me. So sexual misconduct is obviously, you know it when you say it. It's pretty straightforward. But any sort of sexual impropriety, sexual contact, sexual interaction, and they went into some details here. So perhaps you, and again, it's neglectful at least, but you don't tend to have the patient put the robe on. It's just get naked, and I'll do the exam kind of a thing, which is not appropriate. It's not good for the privacy. And obviously that would be a negative for certain patients who therefore may make a report about that. If you have a third party in there and you're not asked, this would include teaching settings. If you're not asking the person about, hey, can I have somebody in the room for like a prostate exam or a GYN exam, that kind of thing, that could be seen certainly as sexually inappropriate. And so that does get looked at by the medical board. Making sexual comments, soliciting a date. Obviously, now you know you're about to cross the line, so they're trying to catch this early. They'd rather catch you asking for a date than after you've been sleeping with the patient, and your outcome will be better as well if it gets caught early. So maybe if I'm a colleague and I overhear Dr. Jones planning a date with a patient and I catch it now, she gets in a lot less trouble. And she puts her bar back up and is like, okay, I'm my boundaries are slipping. And when you look at these cases, it's usually because we are all human, of course, and the physician, him or herself, also is having a life outside of work. And maybe it's not going well. Maybe their home relationship is not going well. Maybe they haven't had intimacy in a while, whatever it is, and their boundary is getting blurred now with somebody who they find attractive as a patient. So that is potentially how that goes. I've covered most of these, I think, pretty well. So sexual contact, I think that one's pretty straightforward. They do specifically mention examining or touching genitals without gloves. So clearly patients will take issue with that. It's, albeit the glove doesn't really, change much of the interaction. They generally aren't being intimate with their significant others wearing gloves. Other there may be a fetish out there I don't know about, but they're not generally doing that, right? So if you are wearing gloves as the physician, then you're setting up a boundary. You're literally saying, I'm setting a boundary. I'm doing this as an exam, not as a sexual act. And so that's why they draw that line very carefully. Sexual interactions, that's straightforward. So we won't need to go through that. Some of these, including the sexual interactions, can lead to criminal charges even. So it gets into a lot more trouble than just the ethical issues involved here. This is straightforward. Obviously, you can damage the victim, right? You're breaking the trust of the doctor-patient relationship. That can affect the family. So if you've had sex with the woman, now the husband's affected. Their intimate relationship is probably forever damaged. Or vice versa, kind of if it's the male and the female. So that is very damaging. And those are the kind of cases that get the worst outcomes, quite frankly, as far as the physicians go. It will potentially damage Dr. Jones as well and her family. So, negative effects overall, the stress of it. And in fact, they've found that many of these people where it was found to be real end up needing psychiatric help to deal with the stress and, relatively speaking, at least the trauma of going through all that after, so many years of education and probably a lot of years of practice. And then to have something happen is, of course, going to have a very negative effect on everybody. It also damages the whole institution of medicine, right? So maybe now I can't trust any doctor. Now I have a problem because I need to be able to trust doctors to go in and get my care. But now I don't trust them because the last doctor took advantage of me in some fashion, some inappropriate way. So that gets into an issue. And of course, that's partly why the medical board exists, again, to police, to make sure that we're protecting that institution of medicine, again, all specialties, and including podiatrists in this case. I mentioned preventing false accusations. So they go into some detail here for each of us as we're watching the webinar to pay attention. Gee, maybe the patient is being overly flirtatious, and we need to really put our boundary up stronger against that individual. Maybe they're being over complimentary about your skill. Oh, you're the best doctor ever. That was the best GYN exam I've ever had. And they're getting into things that yeah, sure, might initially puff you up. Hey, all right, I'm glad to get some good feedback, because we don't always get that every day from patients. But of course, you have to be careful about that pulling on your personal issues, and that could pull you across the boundary line. You don't know, and now psychiatry, we think about this a lot more, I suspect, than other specialties. We don't always know the patient's motivation for coming in, right? So they actually could be recording the session. They might be coming in to get controlled substances, and if they think they have to flirt and cajole and everything else to get them, they're going to do it. They also might want money. They might want to purposely get the doctor in trouble so that they can then sue and make some money. And in our litigious society, that's, again, obviously not far outside of possibility. So they want each of us to pay attention to our own limits, to do our best for our own well-care, so that we don't cross the boundary easily when there's somebody who comes in maybe targeting us on purpose. That's really important. And then importantly, and again, I stress this from my forensic background as well, is to document, right? If your patient is overly flirtatious, document that in the charge, because that may very well protect you if she then makes a claim. It could be a male, but often it's a female against a male physician. If she then sends a complaint, you can say, oh, no. I didn't cross any boundaries. I was aware that something wasn't right, and here I documented it. And I had a chaperone, and I made sure she wore 2 gowns. And I mean, you protect yourself that way. But documenting, of course, is just like in a lawsuit, is going to be key for the medical board when they come and do their investigations. How to report, again, I said come back to this. So there's really 3 opportunities to do it. Again, it's all confidential. They stress that during the webinar because they don't want all those other reasons that we don't report. They don't want those to stop us from actually reporting when we have a suspicion. That is the sum total of the about an hour-long training. I thought they did a good job actually with it. I think having Dr. Levine there to talk some about the sexual impropriety stuff was good. He has seen this for years, as well as, I'm sure, done some work with the state medical board around this. And he's very seasoned in that particular specialty as a psychiatrist who works with sexual issues. So I will take thoughts or questions or any good jokes. It's a tough topic. So. All right, they're all documenting that they've been to the training.
Doug, I want to thank you for your presentation. I appreciate it. That's a good reminder for everyone. I have a comment and a question for you.
Sure.
Do attorneys in the state of Ohio have also the same requirements in terms of their own ethical behavior and expectations? Or is it only medical